and introduce her. We are so excited that Arden Schwinker joined us over the last couple of months. She is certified in things that I know nothing about. You should have the screen, Arden. And it's exciting to me because as a midwife of, now over 40 years and being in a multitude of birth settings, from a birth center to doing home births to starting up a midwife practice in a hospital, things that I'm learning with Arden being on just in this short amount of time, particularly related to fee schedule development and compliance issues, have just sort of made me go, really? Like, okay. So we're thrilled that Arden has brought over a decade of experience to the talents on our team, and that she's here to talk to you tonight and introduce you to some concepts. So I'm going to ask that we all go on mute. If you have questions, you can put them in the chat board or save them for the Q&A at the end.
All right, thank you, Ginger. And I recognize some of you that are on here, and for those who don't know me, like Ginger said, I come with a lot of experience. I spent 11 years at Larson Billing Service as their Director of Operations and Chief Compliance Officer. I am a certified professional compliance officer with extensive experience in coding and billing, and all of my experience is in midwifery and birth centers. Midwifery, birth centers are very near and dear to my heart. And some of you on this call might not recognize me as Arden Schwenker. You might know me as Arden Hamill, because I was only married within the last couple of years. So just wanted to throw that out there as well. Can everybody see my screen? Okay. So one of the things that I know a lot of midwives, birth centers, directors struggle with, especially when you're new, and even when you're well established, is how do I set my fees? How do I determine what to charge for my services? And how do I set my fees compliantly? So that is what we're going to go over tonight, is the basics on how to establish what your fees are, how to set your fee schedule, and how to make sure that it is compliant. One of the big questions that comes up is, what is a fee schedule? Oftentimes you'll set your fee for global midwifery care or for your facility fee, but not realize that you need a fee schedule for every procedure and service that you do. And that's what your fee schedule is. It's a list of your procedures and services and the charges associated with each one. The best way to think about it is, if you do it, if you administer it, if it's a service you provide and you are billing for it, it needs a fee associated with it. Even a routine prenatal office visit that's oftentimes included in global maternity care still needs a fee associated with it in the event that your patient risks out, or in the event that it's a problem-focused visit and you can bill that outside of global. Your fee schedule is also a concise tool that gives your patients and your payers a clear picture of how your practice defines the value of your services. So again, everything you do needs a fee, and every fee that you set needs to be of value. So with that being said, how do you create your fee schedule? This is often the most confusing part in how to create your fee schedule. The very first thing that you need to know when setting a fee schedule are, what are the Medicare rates for the services you provide? And the reason you need to know the Medicare rate is this is the base rate that all commercial payers and Medicaid use to establish their fees. They will use a percentage of Medicare, they will assign RVUs, but the Medicare rate is the very minimum amount that any commercial payer should pay you. If they're paying you below the Medicare rate, then they're paying you too low. So you always need to know the Medicare rate. And then here I included a link for how you find the Medicare physician fee schedule. And you can look up your fees based on your zip code, because the Medicare rates vary based on your zip code. The next thing you need to do in setting your fee schedule, once you know the Medicare allowable, you need to determine the minimum amount you need to charge or you need to get in order to be viable. And to do this, you can look at the following. What is your payer mix? What is your socioeconomic area? So what's your estimated percentage of commercial clients, Medicaid clients, self-pay? Is the area that you're in affluent? Is the area that you're in underserved? The next thing you'll want to look at is your practice expenses. What does it cost you each month to run your practice? How many births does that equal each month? And then build yourself a cushion. Now, when you're setting your fee schedule, one thing that you need to do, one thing you need to look at is being consistent. Every code that you set should be set at the same percentage of the Medicare allowed amount. So for example, if you set your global fee at 300% of the Medicare allowed amount, but your fee for an office visit at 150%, that's not consistent. And the reason why you want to be consistent is it helps you determine the true value of your AR. You should be able to look at your AR, and if it's set at 150% of Medicare, for example, you should know that at minimum, if you deduct off that 150% from your AR, that's the minimum amount you will receive once the payers pay.
Arden, you might pause a second and see if everybody understands that, because this is just critical information. I'm not sure if everybody even knows what AR means.
So your AR is your accounts receivable. It's your claims that are outstanding at the insurance company that you are waiting for them to pay you on. And when you're trying to determine how much money is coming in to pay your expenses, such as payroll, supplies, etc., you need to know how much is sitting out on your AR and how much you may hope to receive from the insurance companies. None of them are going to pay you at 100% of what you build. If they are, then your fees are too low. And that's one thing, we'll talk about it again in another slide, but that's really a crucial thing, is when you're looking at what insurance companies pay you, if you bill $100 for a 99213 office visit and they pay you $100, that fee is too low. You're leaving money on the table. And if I'm going too fast, please stop me, and we will have time for a lot of questions. And that's, again, this slide says the same thing. An insurance company will never pay you more than what you build them. So you don't want to set your fees so low that you leave money on the table, but you also don't want to set them so high that you are alienating people from coming into your care also. It's a fine line. You do want to make sure that you are never billing a contracted payer less than what they're willing to pay. That's another thing. If you set your fee for global maternity, for example, at $5,000, and you enter into a case rate contract with a payer and they're willing to pay you a $7,000 case rate, that's what you bill them. You bill them what's on your case rate, what's on your contract, not what's on your fee schedule. And when you're billing out of network, you want to make sure that your fee is high enough that you are taking full advantage of the out of network plans. I know somebody had asked a question on the advantages of in-network versus out-of-network. And the biggest advantage to out-of-network is that you can balance bill for the usual and customary in most states. Some states have adopted legislation that now prohibits balance billing. But in most states, you can balance bill for the usual and customary. You can balance bill, you have to balance bill for the deductible, coinsurance, and copay. That's really the only advantage of being out of network. If the advantage to being in network is you're contracted, therefore more people will come to you. You will see a higher volume of clients.
Arden, I knew you were going to get this question. What's a balance bill?
Yes. Okay. So balance bill is billing for the difference between what the insurance company paid and what you billed them. So again, I'm just using round numbers because it's easy. So if your global's $5,000 and you bill insurance $5,000, and they say the allowed amount or the usual and customary amount for global maternity is $3,000. So that's a $2,000 difference. If you are in network, you have to write off that $2,000. You cannot collect it. If you're out of network, in most states, you can balance bill the patient for the $2,000. Now, the one thing to keep in mind is if you are out of network and you're balance billing, you have to balance bill every single patient. You can't decide that you're going to balance bill $2,000 to patient A because they were more difficult to deal with than patient B because they were easy and there weren't any issues. You have to balance bill everybody. And I can't see the chat, so you telling me what's in the chat's super helpful.
There's a box, Arden, at the bottom that you could
probably. I know
it's
not coming up on my screen.
Okay. So Patty said, or if your AR is set at 150% of Medicare, you reduce by 1/3 of the total to arrive at the true collectible amount.
Correct.
I think Patty's an experienced biller, if I remember her email right.
Yes. Patty, I feel like you're here for backup for me. Yes, Patty's very experienced. So that's exactly right. If it's set at 150%, you reduce by 1/3. The next thing in looking at setting your fees on your fee schedule is setting your fee schedule high enough to collect legitimate money, to collect what is owed to you, and low enough to not alienate patients when they receive an EOB or call your office asking for your charges. And the reason why this is really important is your fee schedule legally has to be the same for every single patient walking in the door. You cannot charge $5,000 to your insurance patients for global maternity care and $3,000 to your self-pay. That's illegal. That's penalizing somebody for having insurance and will get you in some serious hot water. The other way to think about it is, and I believe that's on the next slide. Oh, it's actually not, but we're going to go there. The other way to think about it is that your client or your patient that walks in your door with health insurance and your client that walks in the door as self-pay, health insurance is just another form of currency. It's the same as if they were paying you with Visa, MasterCard, a check, Venmo, payment plan, etc. Them handing you their health insurance card is just another form of currency. And you cannot penalize them for having health insurance. The other thing you need to know in compliance, and I get this question a lot, if I set my global fee at $5,000 and my patient transfers or transports, can I still charge them the $5,000 for global? The short answer is no. The long answer is no, because you did not deliver the baby. Global maternity care includes prenatal care, the delivery, and postpartum care. If you did not deliver the baby, then you cannot charge the full fee. What you can do is set your global fee for prenatal care and your fee for postpartum care high enough that your refund for the delivery is not as much. But again, you want to set your fees so you're not alienating your clients when they see their EOB. Because no matter what, they will know what you charge them. They will know what you billed their insurance. They'll get an explanation of benefits in the mail or online, and it will tell them exactly what you billed insurance and exactly what you got paid.
So Arden, are you able to give best practice advice if a global, hypothetically, let's say a global is $5,000? Do you think it's fair to call just the birth portion $1,000?
Does it cost you just $1,000 in expenses to deliver the baby?
Yeah, I mean, I guess that is expenses, disposable and non-disposable items, as well as time.
Mm-hmm.
Yeah,
it is. And you need to be able to justify what you're charging. So, I mean, I've seen midwifery and birth center fee schedules that are all over the spectrum. Some are charging a $5,000 global with prenatal care at $3,000, postpartum care at $500. So there you are, $3,500, and $1,500 for the delivery. And that's what they're doing, breaking it out on their financial agreement. But when they're billing insurance, they might be billing $3,000 for prenatal care, $3,000 for the delivery, and $3,000 for postpartum care. And that's not a compliant fee schedule, because it's two different fees for the services. One that's billed to insurance hoping to get a higher payout, and one that's billed to the self-pay patient.
yeah,
so
that's a great example. I think that's a great example of what you mean.
Exactly. So that's where you have to be really careful in how you break your fees out and what you're charging. And fee schedules are a whole nother, or I'm sorry, financial agreements, they're a whole nother ballgame, so to speak. They're the next step after you set your fee schedule. All right, those were all of my slides, because that's really the basic part of a fee schedule, is know what your Medicare rates are for your area, know what it costs you to run your practice, and then set your fees accordingly. So any questions? I'm sure there's a lot of questions.
There's one, Arden, on how to develop a fee schedule for a home birth practice.
So really, it's the same thing. It's the same concept as setting a fee schedule for a birth center. The only difference is you're not setting a fee schedule for a facility fee. If your home birth practice is completely home birth or completely home visits, no in-clinic, you do all your visits in the home, then your fees are set based on the home visit codes versus the in-office codes. I know some home birth midwives charge for mileage, and some build them into the fees. And that's something that comes into the financial agreement. So I'm sure there's more to that question. So if you have specifics, I'm not sure who asked the question, but if there are specifics with that question, I'm happy to answer them.
So why don't we go to an open mic, because that's probably going to work best over the next half hour or so. If you have a question, just feel free to turn your mic on and let us see you. If you're welcome to do that too.
Could you talk a little bit, because this has become a thing politically, where you hear politicians say about fair pay rates for self-pay patients.
Mhm.
And that, insurance companies require you to give them a discount. So the self-pay people want to know what the discounted rate, the truth in fees per se is what you're hearing. So right now we have the self-pay people say, I don't want to know what your fees are. I want to know what you're paying Blue Cross Blue Shield. That's what I'll pay you. So, they're right that you have this one set fee. You're required to give Blue Cross Blue Shield or whoever, I'm just using them as an example, a discount to be in network with them. So you take this discount, yet you're not supposed to charge the self-pay people different. But what you could do, or what I've heard others do, is give an incentive to pay early, which would be bringing the self-pay closer to what a insurance payment would be.
So you have to be really, really careful with self-pay discounts.
Discount word can't be used, right?
The discount word cannot be used. So the compliant way to have your self-pay pay closer to what insurance pays is a financial hardship policy. That's the compliant way. And then you qualify them based on their financial need. You have them fill out an application, you use the federal poverty guidelines, you collect pay stubs or W-2s. That's the compliant way to bring the fee down for self-pay. The other option or other compliant way is if the patient initiates the negotiation first, then you can negotiate your fees with them. You just have to document it. So them negotiating with you first is as simple as them walking into the clinic and saying, Leslie, I can't afford to pay your full rate. I want to pay you what Blue Cross Blue Shield pays you. That's a patient initiated negotiation. Or don't tell me your fee. I want to pay you what Blue Cross Blue Shield pays you. That's a patient initiated negotiation. You just have to be really careful with that insofar as that it's documented clearly in the charts. And the reason being is if you're ever audited, technically a payer is only supposed to be able to look at the charts for their insured. However, once they have access to your files and your charts, if it's an audit where you're sending them information, then yes, they're only going to see their insured. But if they come knocking at your door and show up and start auditing charts and files, they're going to take a look at everything in your practice. And if you deny them access, as is your right legally to deny them access to anyone who's not their insured, then what we're seeing in states right now with birth centers is they're calling in the OIG. And that's the Office of the Inspector General, for those of you that don't know. And that's the last person that you want knocking on your door. So the compliant way is to have them fill out a financial hardship policy or have the patient initiate the negotiation.
So then do you have an established sliding fee schedule, sort of the old fashioned model that I worked under?
You do. I made one on Excel and just take the federal poverty guidelines every year and plug in those numbers. And then you can set the percentages to whatever you're comfortable with for your practice. Like my Excel spreadsheet, I think has 120, 40, 50, 60%. I just reviewed one the other day that has higher percentages. I reviewed one that has a little bit lower percentages. So once you know the bottom line minimum dollar amount that you can accept and still do that delivery, that's how you determine what you want to put on your financial hardship policy. And the biggest thing about your financial hardship policy is that you're consistent. So if you are using the federal poverty guidelines, which is the safest, that's the one I will always tell you to use because it's the safest. Then if you require a pay stub from, like Ginger, if you were my client and I required a pay stub from you, then I would also need to require a pay stub from Leslie and Patty, etc. So you just have to be consistent.
What about early payment discount? What I've been told in New York State is I cannot give a cash discount, but that I can call it an early payment discount. And that if, yeah, like you're saying, if I'm going to do a hardship or sliding scale, I have to have it documented that I've reviewed their documents and, or that they've showed me their Medicaid card. So therefore the feds, you know, the state has already proven they're on it. So that would be another way of doing it, I guess.
Exactly. And like if they show you your Medicaid card, their Medicaid card, you're exactly right. The state's already determined that they're hardship. And if you're not a Medicaid provider, then that is absolutely qualification for financial hardship. An early pay discount, it really, again, you using the word discount is penalizing the people who have health insurance. So you have to call it something else. And I know the state of New York says that you can give well, technically an early pay discount. It's all in verbiage and schematics in some of it. And I'm not an attorney. I'm just a compliance officer, which sometimes feels worse. I don't know. I'm not saying being an attorney is bad, Joe, don't hurt me, because that's what I wanted to be, but I settled for being a compliance officer. My best advice is if you're following your state law, to also consult with an attorney on the proper verbiage.
Thanks.
I'm trying to think, what is another word other than discount?
We
Acknowledgement?
use incentive.
Incentive.
There we go.
Mhm.
I like that.
Yes, Leslie does use incentives. A prompt pay incentive. And the thing is, if your prompt pay incentive is 10% or 20%, I never advise more than 20% simply because that's a huge red flag. But if it's in the lower area, 10%, 15, 20%, that's no different than what you would give an insurance company if they would agree to pay you before the delivery. It would save you a whole lot of heartache and hassle later trying to collect that bill. I'm sure we have other questions.
Yeah, I think they're just being quiet right now.
I think so.
I know several of them and they're not quiet people. It's overwhelming.
It is.
I signed in late and I apologize. Is this going to be recorded and available afterwards?
Yes, it should be available within a week. Our IT team is pretty fast.
Great.
Yeah.
Yep. And Angie, after you watch it, if you have questions, just let me know.
Great, I will. I'm looking forward to hearing it all. I'm a little mad at myself that I couldn't get on here sooner.
Well, if I were listening as a new practitioner getting ready to jump out into the world, i.e. Shayna, I would think, wow, 30 minutes and I know everything about how to do a fee schedule. But in reality, many of the components that you described, Arden, sound very simple, but there's a lot of math behind it, a lot of negotiation behind it, a lot of community assessment behind it, understanding your case mix. That all takes time. And like, how often do you rethink this kind of stuff?
Oh,
Exactly. And
and then
oh, I'm
things,
sorry. Do you have a question?
well, just to comment, things like Paragard IUD. you know, the fee schedule was set, Medicare was that they'd reimburse, I'm fudging on numbers, $350 for the Paragard, which was okay when the Paragard cost me $500 and they were going to reimburse me, you know, $200 for putting it in and $350 for the device and $250 for the visit to check her strings a month later. But then when a month later, the Paragard cost me to purchase it $750. It's now up to $1,000. And the Medicare is always behind, even when the amount goes up. So they're all, you know, they redo their schedules, but they're always behind. And that was ouchy.
And the thing with IUDs, and I'm glad you brought that up, because that is a common question that I get is, how do I set my price for an IUD? So if you're billing Medicaid gets reimbursed for IUDs in most states on what's called a rebate span. So what they're reimbursing you for the device is what the device manufacturer is reimbursing Medicaid in a rebate for them to cover that device. The commercial payers should reimburse you the average, at minimum, the average cost of the device and in your area. So because the device costs different depending on where you're at, some states it's up to $1,200 for the Paragard, which is crazy ridiculous. So what some payers have done to make up for it is they are paying a little bit more for the insertion and evening out the device payment so it's pretty close to what you pay for it. Some payers require the device to be purchased at the pharmacy now, which is dumb. Like, who wants to go pick up your IUD at the pharmacy?
Well, I've never had it work. I've had it, you know, that's the requirement because it's under their pharmacy bill, their pharmacy benefit, but I can't find any pharmacy, and I'm in near Albany, New York. There are none. They just laugh. They're like, yeah, that's what the insurance says. And yeah.
Yeah, they're not going to hand you an IUD.
That's
they're not even going to stock it.
We've gone to, we don't provide the IUD, so you have to do it with the mail order specialty pharmacies. And then they will mail it to you with their name on it. And then that way you're out of the whole IUD purchasing business. The other piece, we do that with all but one, because there's one we actually make a pretty decent amount of money on, but the rest of them, Marina, Skyla, Paraguards, if they specifically want those, then those have to go to the specialty pharmacy, which means they're going to wait. It's going to be 4 to 6 weeks before it can come in, because it's a process. But the other thing is, don't forget the little extra charges that you can find. So anytime you do a procedure, there's a surgical tray. And you don't get a ton of money for that, but every little tiny bit helps. So whatever, and you know, string checks are one of those things that we kind of quit doing because medically they're probably not necessary, but it's a way to get some reimbursement. Patients tend to feel like, you know, you're doing something magical, letting them know that your IUD is perfectly where it is, when they could do the same thing you did, you know, just put your fingers in there to see if you feel a string. But you do get an office visit for it. So
some payers now are not paying the office visit. Yep, they're including it in the primary procedure, which is the IUD placement, but they're paying more for you to insert the IUD to cover the string check. But Leslie's right. And when they come in for the IUD insertion, if you schedule an IUD insertion, a well woman exam on the same day, you can bill for both. you can bill for the well woman, you can bill for the IUD insertion. So basically you're double dipping, so to speak, in one appointment, but that's okay because it's a really good use of your time.
Arden, I think we've had a few issues with those, and it may be that maybe we're not attaching an appropriate modifier. Maybe we need a 25 or something that we haven't been attaching. I'm not sure, but it seems like we've tried to get away from doing that because there were some payment issues. But as far as the IUDs go, we've had pretty good success with reimbursement. And we've actually been able to make a little bit of money on them. Like Leslie said, there's one in particular that we get at a really good price. And, you know, I love it when we put those in because we make a few $100s on those. We just have to stay on top of the Medicaid fees because like you said, as that price changes, Medicaid tends to lag behind in upping their reimbursement. So we have to keep really close eye on that.
Absolutely. And the reason they lag behind is because the device manufacturers only publish the rebates quarterly. So if the Medicaid fee changes at the beginning of the quarter, the fees were already published. So quarter four fees come out in quarter three.
Yeah, that makes sense. I didn't know that about the rebates from the manufacturer to Medicaid.
Most Medicaid.
It's interesting to me that the number is usually to the penny for the Medicaid reimbursement as far as what it costs us. And I had no idea that's why, but that makes sense.
And the other thing to keep in mind with your IUD is if Medicaid isn't paying you what you pay for it, like Patty said, you should be getting paid close to the penny. So if Medicaid isn't reimbursing you at that amount, it could be that the NDC code, the National Drug Code for the IUD is not on the rebates ban, meaning the drug manufacturer, the device manufacturer did not lobby hard enough to get their device on the rebate, and you need to look at purchasing your device from a different manufacturer, from a different rep. So which is no fun.
Yeah. Oh my gosh. Arden, you need a department, right?
Yes.
There's a question from Shayna. I was always taught that you cannot bill a procedure with a well woman code. You cannot bill a procedure with a well woman code. Did that change at some point?
Yeah. You can bill, like if it depends on the procedure. So an IUD insertion and a well woman can be billed together with a modifier 25 on the IUD insertion.
You can also do, it used to be you couldn't do 2 visits on the same day. But that kind of went away for well woman. So she can have a well woman exam at 8 o'clock and at 8:30, your next one on or whatever else that it was that you were going to do. Now, the only problem with that is you do need to chart them separately, but most of us now are using EMRs that have templates that make it kind of, you just hit your IUD template and you're done with your charting. So that's what we always do is when we do an annual with an IUD or an Nexplanon, just because the rules change too. You can, you can't, you can, you can't. So we just book them 30-minute appointments or whatever you want to do, however time, 15-minute, 20 minutes, back to back. Then they have separate appointments. They're on the same day, but they did take away that you can't have the same appointment on or 2 appointments on the same day.
Exactly. And the other thing too is if your procedure is denying with your well woman, then your biller should separate it out into 2 claims. Because it's 2 visits, 2 appointments, 2 separately reimbursable items, 2 claim forms.
There's one thing somebody asked earlier that I just wanted to make a comment, and that was they were talking about losing money in triage. This is something that has been a real thorn in my side when it comes to obstetrical payment is if you do something and it works, you're not going to get paid for it. But if you do something and it doesn't work, you can get paid for it, like a Cook catheter. If you put the Cook catheter in and she goes into the labor and delivers within 24 hours, you ate the cost of the Cook catheter. But if it doesn't work and she doesn't deliver for 3 days, then you can bill for the Cook catheter. So a lot of triage, if they deliver within 24 hours of whatever you're doing for them during that triage appointment, many times that's just revenue loss. So that may be why your facility isn't even bothering with the triage, because so many times they say that's part of delivering the baby. That's, you can bring them in for a SROM check, but we fill out the forms and we send it to our biller, and our biller bills it, and it's always denied, unless the baby isn't born for several days.
You're exactly right. And
Thanks.
I believe the same question is talked about coders from India, and maternity coding is not easy. Maternity billing is not easy because there are so many rules like that. If you do a procedure and it works, you're not getting paid for it. So it could also be that the coders are not maternity coders. They've not been trained in how to code and bill properly for maternity. And then throw in a birth center and a midwife on top of it.
Oh, yeah.
Because that's even additional education and knowledge.
Arden, this may be putting you on the spot a little bit, but if you had the top 3 pieces of advice for someone to create like a top-notch fee schedule, what would it be?
First of all, to know your area, because you don't want to set your fees higher than your competition and price yourself out of the market. You need to know your area. You need to know what your competition is getting paid. You even need to know what the OBs are getting paid. Price shop, secret shop. I've called for several midwives and birth centers and pretended to be pregnant to get fees. So that's the big one. The other one is know the bottom line number also. Know the Medicare reimbursement rates for your area to make sure that you're not getting underpaid. I reviewed a fee schedule for a midwife who was charging, it was roughly $75 for a 99213. Medicaid in her area was paying 82 something.
No.
So she was getting underpaid. She was undercutting herself just off of Medicare.
And they're
And
not
if
going to tell
Medicare's-
you, right?
No, they're not going to tell you. They're just going to pay you that.
Yeah.
So always know, always pay attention. Even if you have outsourced your billing, and your billers should pay attention and make sure that if you're getting reimbursed at 100% of what you're billing, you still should pay attention also. It's your practice, it's your business. You should know your numbers. And then the other thing is just be consistent. Make sure that what you're charging is consistent across the board. And
you can
if
ask a friend or a relative for an itemized bill that recently had a baby or recently went and got an IUD or whatever. If you know somebody who's done, and just ask to see their itemized bill, and we do that periodically every few years. We'll get a bill from somebody locally and compare it to our fee schedule to make sure that we're not selling ourselves short.
I was just about to ask that, Shayna, and we hinted on this, Arden, when I talked earlier. How often do you update your fee schedule?
at minimum once a year. Now, I will caution you this, if you set your fee too low in the beginning, like for example, you're charging $75 and you should be charging $150, You don't want to make the jump from 75 to 150 at one time. You will scare everybody away. You want to step up a little bit. So change it from 75 to 100, 100 to 125, and do it quarterly instead of yearly to get you where you need to be. But the other thing I forgot to mention earlier, in making sure you set your fees high enough that when you go into a contract negotiation with a payer, you're getting paid what you deserve. Because they'll ask to see your fee schedule. Not all, but most payers now are asking to see your fee schedule when they start your contract negotiation. And if your fee schedule is below what they would normally pay you, well, they're going to pay you your fee schedule, and that's a huge red flag. So you want to set it high enough so that you're getting paid what you deserve.
It sounds like the art of negotiating.
It is. Negotiating a contract, that's a whole nother conversation.
Yeah.
But if you negotiate your contract too low in the beginning, then you have to fight with the payer to catch it up, because most contracts are written now that you can only negotiate it every 3 years. And you're stuck with that fee for 3 years.
And they will only go up a certain percent regardless. So let's say you forgot, and they're not going to come knocking and tell you your contract's up for renewal. So you don't renew your contract for 7 years, then they're going to only give you 3% or whatever it is a year. So you have to negotiate. Then I got to go to yearly because I'm behind and I need to catch up.
Exactly. Yes, they're not going to tell you when you forget to renegotiate, you forget to renew, or you set your fees too low. They're going to take that as a win and just pay you a little less.
So Arden, in this time period of COVID and negotiating contracts, are people doing this on the phone or by email? Or are they walking into the Blues office downtown?
Is there anybody in the Blues office downtown?
No.
They look pretty vacant, but no, in the time of COVID, it's almost all done through email. Used to be your rep came in, sat down, your provider rep sat down, talked to you, you had a relationship. Now that relationship is oftentimes built over the phone or email. And most of the time, if you call them, they ask you to email them.
That's if you can get in touch with them.
Exactly. That's if you can get in touch with them. That's the other thing. There is such a high turnover with the payers and provider reps. And so if you are thinking of contracting with a payer and you're not opening until, say, January, I would start now. I would get your fee schedule established now and hire somebody now to negotiate your contracts for you. And it's almost September, so you still probably won't have them by January. It'll probably be Q2 before your initial contracts are done. That's just how backed up all the payers are because of COVID.
So while all these midwives are waiting on their money and they're in the process, they're still billing, right? They can still bill the patient, right?
You can still bill the payer. So the very first thing you want to do is get set up with the payers, get credentialed with them, get set up as out of network so that you can still bill the payer. You can still get money coming in the door. And then when your contract has been negotiated and finalized, then you can bill in network. Some of your contracts may be done before you ever have a delivery. And then you can still bill global maternity care, even if the contract wasn't done before they entered care.
That makes a lot of sense. I see some puzzled faces, but that's really important for a few of you just starting out.
It is, especially because they're so slow right now, especially the Blues. The Blues are running way behind.
I think Linda has a question.
I do. I kind of came in late. I'm a home birth midwife and just started my practice last year. In October, I'm out of network with everyone right now, billing upfront, and then have a biller that I'm using to. I just had my first delivery in July. So that was my first insurance she's billing for that. My biller is, but I guess my biggest question is I'm debating taking insurance. It just seems like such a hassle. Do I even want to? I mean, I'm getting lots of clients. I've got a pretty high cash pay price, and to be out of network. How do you find a credential or a contractor? Do you guys do that? How do you go about finding that person to do that for you? If you're like, okay, in January, by January or second quarter, I think I want to try to get with a couple of payers. How do you do that?
To be in network with the payers?
Yeah.
So,
how do you find that person?
yeah, some billing services have a separate department where they will do it for you. Your biller legally can't do it for you. That's price fixing.
Right.
They can negotiate, or they can email the payer. They can get the contract going back and forth, but they can't settle on your final price. You have to determine the final amount that you will accept. There are contracting companies that will do it. I dabble in it a little bit, but it takes somebody who is very, very skilled in contract negotiations to get you the best price.
Mm-hmm.
So I'm in upstate New York. I have a home birth practice, was out of network with everybody for a long time. Did that same, like, is it worth it? Is it not worth it? Especially since one of the main benefits supposedly being in network is you get more business. And I already had enough business. But it was going to be a big benefit for one, me being able to send a bill and more likely get it paid without quite so many hoops to jump through. And two, a point for my clients that they would, be able to, they're paying for their insurance anyway, they could get it back. So I looked around my area to see who's the big payer, and CDPHP, you won't mean anything to you unless you're up here, but they have almost 50% of the market where I am. So that was the one I was like, okay, well, if I'm going to choose one to practice on and give it a try, it would be CDPHP, and just went down the phone list to find on the CDPHP website who's the provider negotiator or whatever her name was, and called her up and said, you probably have never had a home birth midwife reach out to you, but I'm interested. And she's like, we've been paying through the nose for home birth services because they were paying out. They hadn't figured out at that point that they didn't have to pay as much as we were charging. And anyway, so she was really thrilled to have me reach out. And in the negotiating, it was great because she's somebody that's been doing it for a long time. And so she would keep kind of dropping hints. And then I'd go, oh, are you trying to say? And she's like, well, I couldn't tell you that. I'm like, okay, so theoretically, so I would do that kind of language. Theoretically, if you were talking to somebody, it would mean that I could charge a non-medically necessary service fee for these extra services I give. Like somebody can reach me on the phone 24/7. She'd go, bingo. Right. Yes, you can. And then also she brought up the point of, that my global fee would be X, but for anybody that actually had a home birth, I would get 150% of that fee because they were tacking on my facility fee. I can't charge a facility fee, but she said, once I had to, give her a list of everything I carry in my car. She's like, you're carrying a hospital in your car. We are going to pay you 150% of our normal fee that we would pay an OBGYN or a midwife delivering at the hospital for your home birth services.
Which is excellent.
Yeah.
Because most payers won't do that.
Right. So
they won't even pay a birth center a facility fee.
So it's not
exactly.
It's not a facility fee. It's that my charge for a completed home birth is I get paid 150% of the fee. So if somebody transfers to the hospital, theoretically CDPHP is supposed to pay me less. They usually forget and just pay me the whole amount, which is great. The other thing is that then a couple of years later, another one of the Blues just cold called me and said, we see that we're paying you for home birth services. We want to talk to you about being in network. And so I just said to them outright, sure, we can talk, but up front, you need to be able to tell me that you're going to give me 150, % of the fee, and these are what I already have going, and you have to at least match that, if not above. And so it's still a pain in the behind, but those were things that were really helpful, and clients like it. Even if it winds up costing them the same amount, psychologically, they really like that their insurance is paying part of it.
Right.
And for the office stuff, hands down easier, for the annual exams and the IUDs, that piece totally worth it, being in network, in my opinion, versus cash.
It helps with your cash flow because you get paid faster in network by quite a bit.
But if you're a home birth midwife and you're collecting your full fee up front and then submitting to insurance for reimbursement after the fact.
It doesn't matter, I guess. Yeah.
Yeah, exactly. And that's the thing. I mean, having worked for a midwifery billing service for a long time prior to coming here, a lot of the initial were home birth midwives. A lot of the initial clients were home birth midwives who were simply billing out of network to make your clients happy, because you're collecting your full fee up front. So if that's working for you and your clients are willing to pay you your full fee up front, and you're billing insurance just simply to see what they can get back in reimbursement, then that's great, because you're getting paid everything up front. And if you go in network, the thing to consider is you are not going to get your full fee.
Right. And I
Usually.
understand that. I think for me, it's about trying to let more people get access to a home birth midwife in my area, because right now, the people that can afford me are the people that are, upper middle class. And that's great. I love that they're paying me my full fee and they can, but I would like to give some more access to people that need their insurance to pay because they don't have the money to pay me up front.
So another thing to look at too,
I do a sliding scale. I
Mhm.
do a sliding scale. I do offer a sliding scale, but it still just seems like there's this big gap in those that can afford, and then those that can't afford even the sliding scale to come out of pocket at all.
And are you considering Medicaid also, or just setting up with commercial?
I'm thinking about Medicaid, and that's the other thing that's weird. I'm in Florida, so Medicaid's very strange here because I'm a certified nurse midwife. There's not that many of us out of hospital. So they're really used to the insurances, and Medicaid are really used to the LMs, the licensed midwives, and they're kind of like, I keep getting these risk assessments and things that are required in LM law that are not required for a CNM. And I'm like, I'm a CNM, I don't have to do that. And I'm actually an autonomous practitioner now for primary care. So, why should I have to have a primary care doctor say this client can is okay to have an out of hospital birth? That's ridiculous. So I'm fighting that kind of garbage.
Florida's really tricky too. So as far as contracting and getting set up, like you said, even with Medicaid, but getting set up with the payers, that's something you really want to look at a credentialing specialist who is very well versed with the Florida payers.
Right. And so that's why I was hoping to,
I can
find out a name.
I will find out a name for you.
That would be fabulous.
Linda, I was going to share, I think somebody else has a similar question, which is crazy because we're clinicians, not billers or contract negotiators. Shayna, I think, Arden, did you have your email on a slide, or we can put it up in the chat board?
It's on the last slide here.
Yeah,
let me
but see, I took
enter.
the screen away from you, so I'm going to have to give it back. You can have it back now.
Or I can pop it in the chat.
Yeah, you can email Arden, Shayna, and she could probably give you some ideas of maybe people in Maryland. I can't speak for her. Yeah, there you go.
Yes,
But
definitely.
Shayna also asked this question. I think it's something Michelle hinted at. What do you think of administrative fees to non-Medicare patients for things like 24/7 availability?
You have to watch your payer contracts. So most payer contracts prohibit you from charging administrative fees, and some Medicaid contracts prohibit you from charging administrative fees. So sometimes you have to call it something different, like a registration fee or a non-refundable deposit to hold your space, because you can only have so many people on your roster every month. So depending on your state and your payer contracts, if you have even one payer contract that prohibits you from charging an administrative fee, you just need to call it a registration fee
That's
or
what
a
we,
non-refundable deposit.
I'm waiting for Leslie to say something.
we have a registration fee. When they ask me what that is, I say it is a combination of holding your spot, and it also covers things that insurance doesn't reimburse us for, which you are allowed to. And for example, water birth, because you don't get anything for that. Yet it's a big expense. You got to do the laundry, you got expensive tubs, all the equipment that has to come with it. So that way, irregardless of which insurance company, because one may say you can charge for things that you don't get reimbursed for, and one can say you can charge for this holding your space, but one may say you can't, the other one. So that's why it's a combination of the two. It covers everybody.
Exactly. And having read Leslie's contracts in detail, a registration fee is perfectly acceptable. Like that covers you with all your payers. And then you make sure it's non-refundable.
Yes.
And
we
that's
make
one
that
thing
very-
you want to make sure is in your financial agreement.
It's
is that the
non-refundable,
registration
and
fee
they
is
know that it's
non-refundable.
not, they cannot bill their insurance for it. I tell them
Correct.
if they want to try with an HSA, go for it. And if they pay you, fine. If they don't, they don't. I can't say that an HSA will or will not reimburse you for it. But this is not something that you can bill with your ask your insurance money back. And it's mine. I tell them the day you hand me that check, it's mine forever and ever and ever. Amen. Done.
Mhm.
You transfer 5
Exactly.
minutes later, it's still my money.
That's right. And the thing too is most HSAs, if it's an HSA credit card and you're a healthcare provider, they'll allow them to pay the registration fee with it. Some flex spending accounts won't, but the HSAs will.
We're going past the hour a little bit. Here's my giant Labrador retriever. If there's a couple more questions, let's field them, and then you've got Arden's email as well as a resource.
Hey, Ginger, this is Kate. I don't have a question, but I do, I guess I do have a question for Arden. So our situation here is very different from what this topic is about today. We're not a private practice or a birth center. We are employed by the hospital. And so I'm just wondering if maybe at some point we could do another session on hospital-owned practices and maybe some tips for us on fee schedules within that bureaucratic nightmare, and how we as midwives can be a little more business savvy when it comes to our charges and our reimbursement and kind of what we're worth, because that seems to be an ongoing dilemma in the area that I'm in. Does that make sense?
Yeah, but Kate, do you think that your worth is any different whether you're in a home, a birth center, or a hospital in terms of setting that fee schedule?
No, I don't, but I don't think that we have the ability to set a fee schedule. And so I'm just wondering, like when you are employed by an institution, how do you find out that information, and is there any room for negotiation? Like
Interesting.
what would we do in that situation, since we have very little say so in those kinds of matters? Does that make sense?
No, that makes sense. And the thing too, and I totally understand what you're saying, because you aren't able to set your fees. The hospital is setting them for you. But the thing is, if the hospital is billing the charges, which they should be under you for rendering the care, then you should know what they are billing
That's
under your name, because ultimately you're the one responsible for it, not the hospital.
Okay, I
So
guess
that's how you
that's
get your
another
fee schedule.
conversation.
I was
That'll
going to
be-
say the same thing, Kate. When I started a practice at a hospital in Kansas City, we had 10 midwives, and the maternal fetal medicine doc, the CFO, and myself did the negotiating for the fee schedule. So there was input by me, but I always knew and had a great deal of control over that. I think that's a great idea for a session, is the strategy behind how large, whatever size midwifery services that are employed by owned by a hospital can navigate and negotiate those complex conversations.
Absolutely.
I will sign up for that webinar.
Well, I
And-
just made a note to put one to, that we should look at putting one together.
Yeah.
Angie Arden joined Grow Midwives as a consultant, so absolutely she can be hired as a consultant.
Yes,
Lovely.
absolutely.
Lovely. I want to catch babies and provide care. I want you to make sure I'm billing for it appropriately.
I would be more than happy to help you make sure that you're billing appropriately for catching babies and providing care.
Wonderful. Thank you. I'll reach out.
Great.
What we've been learning on this journey as we as a team have pushed ourselves a little bit. Many of you know that we created the Performa so you can understand the business metrics of just what's it take to start a business and how to keep yourself going. We then learned and realized Arden's availability to help really focus in on the topic of tonight and making sure people get the money they need to be sustainable. And the next product we're going to be pushing out really soon is how to make a schedule predictable to when do you hire the next FTE, and how do you know you have enough slots in your schedule by the kind of volume that you want to generate. So we're really trying to hone in on those key areas of fiscal accountability. That we can love our work as much as we want, but if you're not getting paid, you're not going to be doing it forever.
Exactly. And that's one thing that I love about the work that Grow Midwives is doing. And one thing I was really happy about joining Ginger and Leslie is just the focus on making sure that midwives are getting paid what you're worth, how to grow a sustainable practice, how to make sure that what you're doing is viable.
And compliant.
And compliant.
And
And
compliant.
I think Shayna said something earlier about compliance being scary. I 100% understand that. I thought compliance was scary at the beginning also. But one thing that I am here to help you with, in addition to fee schedules, is help you know what you need to do to be compliant. Because it's always changing. And the rules change every year, sometimes every quarter. Literally in 2020, the rules changed over and over and over because of the pandemic.
I think what makes it difficult is the fact that you can't start like many physician practices do with a large administrative team. You're
Mhm.
starting with a bare bones structure. And what are those essential elements and ingredients you need to get started so then you can build your administrative team that can help you over time, depending on how big you want to grow. And so it is overwhelming, Shayna. Like, how many things am I supposed to know when I'm a midwife to make sure I start a business that is legally sound, making me money, I have enough staff, and all the bills get paid. It can be overwhelming, but it is doable. We know that. We have people right in front of us who have done it. You just need to be, you need to know where to go for help if you need it.
Mhm. Exactly. And you need to know what to keep internally and what to outsource.
Somebody asked me privately, and I don't mind sharing it publicly, so, or on this group. So I'm happy to tell you, my registration fee is $250. And we are a birth center practice.
And Leslie, I think you and I have consulted with a birth center who charges 500.
And I've worked with a lot of birth centers that charge 500. It's again, knowing your area. And is 500 an amount that will scare somebody away?
Yeah.
So what we do, yes, we charge $250 for our registration fee. We charge $250 for our childbirth class. And if you're a prime, if it's required, because that lowers our transfer rate. So I would rather have a lower transfer rate and get the bigger facility fee. So we discussed going up. That's why we left it at that price, because we are requiring, it's not optional.
And one thing too, this just dawned in my head. When you're charging registration fees, for those of you that serve a high military community, you can choose to not charge your registration fee to the military, and that is fine. I personally would still charge it because TRICARE doesn't pay you enough not to, but you can choose to waive certain things for the military. You can't waive their deductible. You can't waive their cost share or their co-insurance. The military TRICARE calls it cost share, but you can waive a registration fee if you chose to for military.
We're a military town and we have a lot of TRICARE, and they don't have any problem paying it.
And most of them don't, because they don't want to deliver
Neither
on
does the
base.
Medicaid. They're okay. I mean, yeah, I'm sure there are some people who don't come because of it, but not that many. It's not enough that it makes the difference.
So can I ask one more question about that? I have written into I'm out of network and everything, but I have a 10% I have a 10% discount for first responders, active duty military, and missionaries or full-time ministry. Is that okay?
Mm-hmm. It's 10%. You might want to call it a 10% incentive.
Okay.
But it's totally fine.
Okay. And it's, because, a lot of mine are paying, like I said, they pay up front and then I just get back. So what I call my upfront fee for people that are doing insurance is my upfront prepayment of their insurance copay or whatever, so that they just get the reimbursement afterwards. But that's okay, even if they have insurance, is I guess my question. It's just a 10% discount on their prepayment.
So you can't discount, like, for example, if you're collecting $2,000 from them and you discount it to $1,800, you can't bill insurance $2,000. You have to bill insurance $1,800.
Right. Okay. But if their insurance is, since I'm out of network, if their insurance deductible is $5,000, they are prepaying me up to my charge, and then I can only charge insurance $4,500 or whatever that is, even though my charge normally to insurance is higher. I'm just letting them not pay it up front.
Okay, well, that's a whole different issue. You
Okay.
cannot discount deductible, co-insurance, or copay.
Okay.
Without
Okay.
a financial hardship agreement,
Okay.
even
Okay.
though you're out of network.
Okay. All right. Okay. I will probably have to get with you and have you look over my
It's all
contract.
about compliance, man. I remember the good old days when the Blues came in the front door of our birth center with a basket of, cookies and sat down and talked to us about fee schedules. That is long gone.
Mhm. Mhm.
It's almost like another loophole you got to figure out how to jump through with the right
Mhm.
language.
It is. And your financial agreement, once you have your fee schedule, is another loophole you have to jump through.
Yeah. Well, I hope this has been helpful for those of you that have been on. I know that may leave you with a lot of other questions. You got Arden's email. We're thrilled you were here, and feel free to share with your friends and colleagues. This will be up on our website soon. And stay tuned. We don't know what the next webinar is, but something will be coming.
Thank you, everyone.
Good night.
Good night.
Night.
Bye.
There.